I think I'll request Dr. Himanshu Matalia. He has a flight to catch, so we just are requesting him to give his talk earlier. He'll be talking to us on visual rehabilitation in keratoconus.
Thank you, Dr. Ashish, and I really appreciate all the rest of my speakers to allow me to speak ahead of them. I do not have any financial disclosure here, and I'm going to talk about visual rehabilitation in keratoconus. So when we treat keratoconus, we basically divide up, all of us have our own ways of treating the keratoconus. What I do is I divide cone into either central cone, make sure that center cone either I reduce the spherical equivalent by putting an intracorneal ring or stop the progression by using cross-linking treatment. If it's a decentered cone, I again make the cone centered using one of the treatment like intracorneal rings or a topo-guided PRK and then do the visual rehabilitation. If it's an advanced cone where the options are relatively limited. Remember, whatever we do the treatment of keratoconus, the ultimate goal is visual rehabilitation. So if you stabilize the cone by doing cross-linking, ultimately you have to visually rehabilitate the patient using whatever works in your hand, whether it's contact lens, topo-guided treatment, Intex or phakic IOL. So if we take one by one, let's talk about the contact lens. So one such case who came to me, young girl, was referred for cross-linking, and on Pentachem the pachymetry was 384, which is still manageable in collagen cross-linking. However, in these advanced cone, when you do an OCT, ASOCT, you realize that the stromal thickness actually is much less than what you actually saw. There is significant amount of epithelial hypertrophy on the tip of the cone or apex of the cone, and hence was not the best case for doing collagen cross-linking. Patient was offered a scleral lens and patient had a vision outcome of 6/6 parts. So somebody who had vision which was absolutely less could be fitted with a contact lens and would get a really great visual outcome. Remember what we learned from here, that Pentachem sometime can give you a wrong reading of pachymetry and ASOCT can give you more accurate results. Coming to the second part, intracorneal ring implants. These are the small PMMS segment which we put into stroma to flatten the cornea, to reduce the spherical equivalent. How does it help? Well, using your femtosecond laser, or earlier we used to use even the manual dissection, we flatten the cornea, and ultimately what it does, it centralizes the cone, it makes the cone relatively regular, and then thus visually rehabilitates. Well, with all those contact lenses in place, more commonly now, these are the treatment which I would vouch for in post-LASIK ectasia. One such case, if you can see, the ectasia is more in the inferior part, whereas the superior part is still flat. So a single ring implantation inferiorly would actually do the trick and make the corneal surface look like as if it is just a cornea after LASIK, and there's significant amount of visual rehabilitation much earlier then. So what do we learn from here? That intracorneal ring implant can improve the quality of vision, works for mild to moderate case, for low spherical equivalent, and best use for post-LASIK ectasia. Coming to the next part, which is phakic intraocular lenses. Where do we use them? Well, the cones which are relatively centered, where the spherical equivalent is relatively higher. It's very important to remember that not every case is suitable for phakic IOL. You can see here one such case where it had undergone cross-linking earlier and intracorneal ring implants a couple of years back, had a residual spherical, high spherical and cylindrical outcome, decent anterior chamber depth, and what we are doing here is I'm putting a phakic IOL inside the eye. The surgery remains simple, it's nothing great about it. The only thing is sometimes because of those intracorneal ring implants, visibility may be a little bit disturbed, but by tilting the eye, you may be able to get away with such kind of thing. Set the lens, and what you get is a significantly improved visual outcome. Remember, you're only treating sphere and cylinder, hence your higher order aberrations are still going to be there, but it reduces the significant amount of sphere and cylinder. So what do we learn from here? The phakic are best reserved for centered cone, works for high spherical and cylindrical outcome, and beware, sometime topo and refraction may not be matching each other. If case somebody who is little older age group may require cataract surgery, one such case which has an axial myopia along with a stable keratoconus and cylinder, well, I'm using customized toric IOL here. I do not have any financial disclosure. So here the customization is more about the spherical part, which is minus 12.5 with the cylinder of 4.5. Post-op patient did excellently well and could be treated with mere spherical and cylindrical glasses. So where do we use these things? Well, where the spherical and cylindrical power are matching each other, or rather cylindrical power and topo axis are matching in the relatively center cone, you can use your toric IOL. The final part is topo-guided PRK. The topo-guided PRK works in cases where the pachymetry is relatively good and the cone is either centered or slightly decentered. If it's too significantly decentered, remember, to regularize the surface, you would be burning significant amount of cornea. So when you look at here, the cone which is relatively centered or paracentered, after topo-guided treatment actually became like just a vertical bow tie pattern, and we could actually achieve the outcome significantly. Patient was given a soft contact lens and did well. So yes, we can improve the irregularity on the surface, but remember, there is a limit to which you can improve the irregularity on the surface. If it's an advanced cone which does not give you any other option but to do a deep anterior lamellar keratoplasty, I'm here doing a femto-assisted mushroom graft. Deep anterior lamellar keratoplasty helps you to retain your own endothelium or patient's own endothelium, and works wonderfully well, whereas the shaped graft like mushroom graft can help you to improve the suture-induced astigmatism and can help you to visually rehabilitate patient much faster. To summarize, the keratoconus treatment is based on individual location of the cone and spherocylindrical status of the eye, and can be treated significantly and can visually rehabilitate patient very soon. Thank you very much. And I again want to thank organizers and the chairperson for allowing me to present first. Thank you.
Thank you so much, Dr. Himanshu, for sharing this. These were like pearls of management of keratoconus. And I think the most important takeaway apart from the pearls was that we need to keep the end visual outcome in mind before doing any procedure in keratoconus patients, whatever we do. Okay. Thank you so much.
Thank you, Doctor.
Safe journeys.